stavite manually, ne automatic.
Yeah, it's manual.
Aha.
Ovdje imamo studenticu, ona će pomoći.
Super.
Yeah. No, stavite tu.
Je li studentica medicine?
Nije.
Evo, ona može odgovoriti.
Srednje škole.
Srednja škola, pa lijepo, dobro.
Vidite li prezentaciju?
Vidim prezentaciju, sad na ovaj slide show, molim te, idi tamo i stavi manually, don't automatical, ne automatski.
It's manual.
Ja mislim da vam je tu već namješteno.
A ako je namješteno, ok, dobro. Dobro. Vi samo kažite kad mogu da počnem.
Možete, izvolite sada.
Okay, I continue in English.
Yes,
my name is Dragan Bajić, and I'm pediatric radiologist from Uppsala University Hospital in Sweden, but originally I'm coming from Rogatica. My wife is from Sarajevo, so sometimes I have feeling that I'm from Sarajevo as well.
Wow.
So
Možete li približiti mikrofon, samo da vas glasnije čujemo?
Okay, I'm coming, but problem is that I cannot see the whole presentation.
Do you see any slides?
Okay, probably no. I cannot.
Are you sharing screen with me?
Okay.
Did you move, Dr.?
I cannot move. I cannot move. That is not on. Now I can do it.
Okay.
No. I cannot.
Give him control.
Možete li sada?
No, I cannot move.
Not draw line, the share control, give us control. Yeah.
Možete li sada uzeti prezentaciju?
What you say?
Možete li provjeriti, možete li sada micati slajdove prezentacije?
Side control.
Možete mi staviti u play position.
Ok. Sad?
Ne.
Anyone in the room who is wiser than two of us here?
It should be.
Raja, can you help?
No,
That's
His presentation
his
here.
presentation is here.
I don't hear you.
No problem. So you're not able to control the mouse. Can you run it in this format without the presentation mode? Can you move your slides like this? Are you able to hear me?
Yes, but I hear you very bad.
We can move the slides for you.
Okay. Okay.
We can move the slides for you. Just click here.
So we can continue
Just
with
say
slide
next
number 2.
Yeah.
Next slide. Okay.
Move forward.
Yeah. So
We will move the presentation for you. You just say next slide.
Yes.
yeah, he said next.
Okay, go to the next.
Okay. You see?
Yes. Okay.
Okay, good. Thank you.
Okay, the same. You have to help me. Okay, now we can briefly we can see briefly embryologic development of the kidneys, and that's between gestation week 6 and 9, and briefly anatomy of the kidney. Next, please. Yes, we are mostly interested in pediatric praxis in urinary tract infection and developmental anomalies. We can do with MRI urography. Can you come back? Yes, thank you. For malignancy, but CT is often sufficient for malignancy. Next, please. Regarding urinary tract infection, urinary tract infection, we can differ infection under 2 years and over 2 years. But MRI urography is mostly interested in the complication of the urinary tract infection, as renal scarring and hydronephrosis, which are early complication. And can you come back, please? And late, that's okay. Next. That's late complication as high hypertension in children and young adults. And next. And in young women, it could be preeclampsia, which could be late complication of the renal scarring. Renal scarring are associated. Can you come back, please? Renal scarring is yes. Can you do anything that I by myself have control of this? It should be better. Renal scarring.
You have to be
Так,
back
где кликнем?
to PowerPoint.
He may have done it his way. So that's he has.
Presentation.
Yeah.
It's automatic.
So we just have to be careful. Can you please just I go. Yeah.
Okay, I continue in this way. Next, please.
This is the order. Okay.
I would say a couple of words about renal scarring. Next, next slide. Okay. That's associated with parenchymal reduction, deterioration of the renal function, and development of the hypertension. About 30% of children with hypertension has renal scarring, and MRI urography help us to staging of renal deterioration. Next. Hydronephrosis is the next early complication, and it is in connection to severe pyelonephritis, often because of obstruction. And there is some benign hydronephrosis, for example, in young pregnancy women, and they hydronephrosis. Often we don't need treat. Next, please. Deterioration of the renal function is determined by development of the renal scarring, worsening or persistent vesicoureteral reflux, and worsening of hydronephrosis, decrease in decrease in differential function. Initial imaging workup before we started the MRI urography somewhat differ between under 2 years and over 2 years, but ultrasound is our most useful tool. Next. routine imaging have to identify obstruction accurately, and challenges to do differentiation of obstruction from non-obstructive dilatation, and find out if some patients should have benefits from surgical intervention, and as well predict renal function deterioration. Next, please. Maybe I can continue this way. No. Can I see my next image?
This one?
Next image, please. Do you hear me?
Yes. This is you were on this slide, and we're going to the next slide is this one.
Now I have, there is not, I cannot move anything here. No.
You're trying to move the slide or the pointer?
It's not possible to move anything now.
Back again, and then stop share and try to share again. Okay, can you please share again?
Yes, I hear you, but now I have my presentation.
Yes, can you share your screen again, please?
And now I have a logo on I can see only logo.
Can you share your presentation with us?
You have to open your presentation and share the screen again.
Yes, probably. It should be best to come to Sarajevo, but unfortunately, I had some problem with my car, so couldn't come.
If you bring your presentation to the slide that you want to show, and then share it, because we cannot see your presentation here. The slide that you wanted to be shown.
How I can do it?
You have your presentation on your monitor?
No, I have not.
You don't.
I have only logo. Bosnian Herzegovina American Academy of Arts and Science. That's
Okay,
only I have. I have no presentation on my.
Okay, so he doesn't have share. Now you see it.
Now I see it.
Okay, so you want us to show you this slide, or this is the slide before?
But now I cannot move anything.
We will move it for you. What do you want to move?
I would see next image. Now the image is nephro-urology, nephro-urology imaging, and this I would show next image.
This is the next image.
Yes, urography.
Mm-hmm. This is the next CT after urography. You can see the urography slide?
No.
You're not seeing the urography slide. We can see it here.
I see nephro-urology imaging, the previous image I can see. Image number 11 I can see, but not number 12.
We are seeing number 12.
Yes, I would talk about 12. Yes, okay. Yes, we continue. I'm sorry because of these technical problems. Though we have urography as a historical method. There is no any indication for use of urography nowadays. These images show hydronephrosis bilaterally. CT, can we come back to CT? The only indication for use of CT in the pediatric in the pediatrics is kidney stone in preparation to asphalt treatment to clarify stone position and attenuation. Next, please. Our most important tool is ultrasound. Next, please. If we would show urine bladder, we use voiding ureterocystography, which is gold standard for vesicoureteral reflux. Next, please. Here we have some example of the voiding of the vesicoureteral reflux. That's grade 3 bilaterally, grade 3 on the right side, grade 2 on the left side, and grade 5 on the right side with ureter cell. What is important? Grade 3, 4, and 5 we treat, but grade lower than 3, 1, and 2 we don't treat. Next, please. Here we have example of the urine bladder in the boy with ureteral valve. Next, please. Actually, we have no gold standard in diagnostic test for identifying kidneys at risk and renal function deterioration. But MRI urography could possibly became gold standard for that. Next, please. MRI urography has started in the late 1990s, and we started between the first. Our first performed was 2002. Next, please. When we do MR urography, we use two types of sequences. Pre-contrast sequences, which are morphological sequences, and post-contrast sequences, which are dynamic or functional sequences. Next, please. How to prepare my children for examination. That's a rule, nothing by mouth for fluids 30 minutes before study. And if a child is sedated, we use this formula. But if a child is not sedated, we use this simply formula 10 milliliter per kilogram. Next. Here we have example of the how to prepare the child which are sedated. So if a child is 22 kilo, 4 milliliter per kilogram per hour. So I can show this later on if you are interested to discuss. Next, please. Arm should be above the head, and we use body coil in combination to spine coil. But if you have a Siemens machine, everything we can do on the body coil. Next. Localizers we do with trophy sequence. And what is important, after localizers, we can do furosemide. Next, please. First sequences we perform, that's haze sequences. And they has a great sensitivity of the fluids, and that's fast acquisitions time. It's about 1 slice per second. And that's possible for using breath hold techniques. We do it in 3 plans, coronal, transversal, and sagittal. T1 SE we use as the next sequence to distinguish between fat and fluid. It takes about 3 minutes. Next. T2 TSE, that's a sequence with very nice differentiation between cortex and medulla. And it takes about 3 minutes. Next. 3D urogram, it takes about 5 minutes, and we do MIP reconstructions on this sequence. Here we have example of the left-sided hydronephrosis and dilated on the right side. As I said, it takes about 5 minutes. Next, please. My favorite sequence, blade. There is this sequence show very that's the lowest level of the artifacts in this sequence, so we can do very nice differentiation between different tissue. Urine bladder we do with T2 TSE, and it take about 2.5 minutes. And next, which is very can we come back on the 30 before?
I don't think we should discuss it.
Can we come back on urine bladder? Yes, thank you. What's very important, that's timing should be all previous sequences should be between 15 and 8 minutes. And because the maximal effect of furosemide is during this time, and that's the time which is optimal for the injection of the gadolinium. Next, please. After that, we start functional sequences, and there we use BHAAAS sequences. BHAAAS is very nice to give us good contrast after contrast media, but that's poor tissue contrast. Suitable is to follow a gadolinium bolus, and before we start, we use 2 sequences before injection of the gadolinium, and after that we perform every 20 seconds after every 20 seconds new scanning. And next, please. We try to see this renal perfusion, And on this, we can see a very nice differentiation between cortex and medulla. And next, equilibrium phase, there we can see that that cortex and medulla became iso-intense. And in this phase, we do every calculation. First sequence, before we can see a collecting system we use for our renal function calculations. Next, please. Here you can see how nice is differentiated between the collecting system and cortex and medulla. Next. Post-processing is, it takes a lot of time, but it is somewhat promising results using artificial intelligence. With AI, there is some new programs that this post-processing can become shorter. Next, please. Now we're coming to interpretation of the morphological images. First of all, it's renal size. After that, degree of collecting of system dilatation, and to show if it's intrarenal or extrarenal kidney pelvis. And atrophy or absence of pyramids is also shown. On post-gadolinium images, we can show if is any fluid level formation, and if it's fetal folds, if there's any crossing vessels. And in functional evaluation, we measure the renal transit time, and that's time between renal cortical enhancement and contrast excretion into ureter at the level of the kidney's lower pole. And if this transition time is 6 minutes and lower, that's the normal. But if it's more than 10 minutes, it shows obstruction. That's that's obstruction, and on this way we can distinguish with obstructed or non-obstructed dilatation. And after that, we can measure the split function. Here we have a comparison between Mach 3 and MRI urography. On the right side, on skin, that's different, right and then left. That's the left, that's the right on Mach 3. And we can see that there is no any signal in upper pole on the right kidney. On MRI, we can see that there is very dilated part of the collecting system. So here we have double system with and this upper pole has only 3% of split function of the kidneys. Lower pole is 45%, and then left kidney is 52% of the function. Every function which is lower than 10%, that is suitable for surgery treatment. Next, please. Here I have some examples of the MRI urography. That's 3D MIP in the bilateral hydronephrosis. Next. That's scars, which is very important to find in our patient. Here we have scars on the left side and on the right side, and that's multiple scars with hydronephrosis bilaterally. Next. Here we have on the left side hydronephrosis and solitary scar. That's here. That's here. Next. Here we have multicystic disease of the kidney, and here we have this. This is kidney, and on the right side, that's the normal. That's the normal kidney. Next, please. Here we can see shows kidney on T2 weighted images, or that's the transversal, coronal, and sagittal. Next, please. Here we can see double system on the right side, and most often the double system is in the upper pole, and it happened sometimes that's dilated is lower pole, but most often is in the upper pole. Next, please. Now we can see duplex with mega ureter. Here is in T2 sequence, and that's on wide. But here is a normal ureter from lower pole, from here. Next. That's very nice to see some entities which is not possible to show on other way. For example, we can see this ureteral ectopia, and we have 3 years girl with typical continuous drip urinary incontinence. Ureter is ending in the vagina, but not in urine bladder. Next. 13 years old girl with hematocolpos here. Urine bladder is here, and that's ovary, right ovary on the with cyst. Next. And what is advantages of the MR urography? That's multiplanar capabilities and wonderful anatomic resolution, excellent soft tissue contrast, and split function assessment is possible, but does not use any ionizing radiation. Next. What is disadvantages? It's some technical limitation, including respiratory motion artifacts, and that's problem with sedation. When I worked in London on Great Ormond Street Hospital, they did deep sedation, and actually there is no huge difference between the general anesthesia and deep sedation, and we tried both of this or this approach, and it was nice and both. And that's price, that's expensive. But what's the problem in the whole? When we do all all other examinations, that is not so expensive as before. Next. Yes, MRI is very MRI has a very promising potential in the evaluation of the vesico-urethral reflux. And next. Thank you for your attention. These boys are teenagers. He is 16, he is 15 now. Thank you.
Cute grandchildren.
I'm sorry because of these technical problems, but finally.
Thank you so much, Dr. Dragan Bajić. We appreciate your time and showing us this interesting presentation about kidneys and in young children. It's very important, and I apologize for these technical issues that we had. We didn't expect that to happen.
I have a question. So you presented patients, pediatric patients. What about adults? Is it more useful than CT urography or CT urography?
I don't hear if there's any question. Can you?
1 second.
Yes.
Using this.
You presented pediatric patients. I have a question regarding adult patients. Is MRI urography going to be used more than CT urography, or still CT urography will remain standard in adults?
Actually, CT should not be used in the pediatric praxis because of even nowadays CT has quite lower radiation and old machines.
But what about MR urography in adults?
Yes, we do MR urography in adult, but that's somewhat other approach than the hair. Here is approach regarding mostly infection and complication of infection, and adults it could be used. It could be used, but in adults, I by myself, I do on my department more CT than MRI urography. If it's young people, tip 20, 22, we can use MRI, but actually CT, especially in a malignancy, that is that is CT, which is sufficient to do.
Thank you.
Thank you so much, Dr. Bajić.
Thank you.
Thank you.
Bye.
Bye-bye.
Should I end it?